Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about amitriptyline. Amitriptyline is an antidepressant that was approved in 1961, about half a century ago. Came on the market as Elavil. Now it's available as the generic product only. It's in the class of tricyclic antidepressants. It's distinct from the selective serotonin reuptake inhibitors, the SSRIs, medicines like Prozac and Celexa and Zoloft. Even though it's an antidepressant, it has a lot of off-label uses. In fact, it's more often used for things other than depression. It's on the World Health Organization, the WHO list of essential medicines. It's used to treat not only depression, but also anxiety, attention deficit hyperactivity, ADHD, or pain, low back pain, or fibromyalgia, or chronic fatigue syndrome, or people who have neuropathic pain, like the pain associated with diabetes, or maybe after shingles. It's used to prevent migraine headaches and to treat tension-type headaches. It's used to treat insomnia, people who have urinary urge incontinence, where they seem to have to go and got to go right now. People with obsessive-compulsive disorder, people with chronic cough after an upper respiratory infection that seems to last for months and months. People with IBS, the irritable bowel syndrome, or cyclic vomiting syndrome, or people who have persistent itchiness of the skin. People who retch or develop dry heaves after they have surgery for reflux esophagitis. It's used for people who have certain biliary disorders where the bile duct joins with the small intestine and goes into spasm, a condition that we call biliary dyskinesia. Seems to be helpful. People who have nighttime bedwetting or even early stage Parkinson's disease associated with depression. Comes in a variety of forms, comes in 10 milligram, 25 milligram, 50 milligram, 75 milligram, 100 milligram, 150 milligram tablets. The dose for depression, just for depression, start off typically at about 75 milligrams once a day, single dose or divided doses, start low, gradually increase by 25, 50 milligrams. The maximum dose should be 150 milligrams, but most people should not require more than 100 milligrams, but it might take a month to get the full benefit. Now, the medicine is associated with tiredness, so as a result, you should take it probably, if you're going to do a single dose, maybe hour and a half before bedtime or right at bedtime. For conditions other than depression, it typically is used as a much smaller dose, a dose of 10 milligram, 25 milligram. Start low and gradually increase if appropriate. If it's going to be used for depression, it should not be used in those individuals who have a history, family history or personal history, of mania or hypomania or bipolar disorder, or people who have made suicide attempts. Now, the medicine does come with a variety of side effects. Side effects include dry mouth, blurry vision, sleepiness and constipation, weight gain and difficulty urinating or urinary retention, especially in older individuals. It causes the blood pressure to fall, especially when you stand up, which is a problem for senior citizens who have to get up at night to use the restroom. The blood pressure falls so low that they become dizzy or faint. Fall down might break a hip. It also might cause headache. And there are sexual issues with this medicine that affect men more so than women. It decreases the libido and decreases arousal. It can cause erectile dysfunction and interfere with ejaculation and orgasm. It can lead to sleep disturbances. Even though it's used as a sleeping pill, it can cause insomnia in some people and nightmares and certainly drowsiness. It can increase the sensitivity to the sun, which is a problem, of course, in the summertime, increase the body temperature, and slow down the bowels. It can lead to cognitive difficulties, and especially in people who are predisposed to cardiovascular problems, a racing heart rate, arrhythmias, especially in people who have what we call a long QT interval, especially in those people, lead to severe problems. Can cause breast swelling in people who have narrow angle inside the eye, can cause a flare of narrow angle glaucoma, can lead to suicide, especially in people under age 24. but can cause it at any time, of course. It has anticholinergic effects, so that worsens the problem in elderly men who have an enlarged prostate, or people with a narrow angle glaucoma, or people with thyroid issues, or some people with dry mouth already. Can lead to a peculiar taste in the mouth. And it can have some adverse interactions with other drugs. Drugs in the SSRI, SNRI family, like Celexa or Zoloft or Cymbalta or Effexor, can interact with the triptans that are used to treat acute migraine headache, or Lyrica or gabapentin. Can interfere with antipsychotics, the Abilify or Haldol, that were originally used just for schizophrenia but now used for depression and used for a variety of other disorders. Can interfere or interact with cimetidine and disulfiram. Cimetidine, of course, Tagamet, disulfiram for alcohol abuse. Antithyroid medicines are tramadol, levodopa, alcohol. And you shouldn't take amitriptyline within 2 weeks of taking an MAO inhibitor. MAO inhibitor also, of course, for depression. MAO inhibitors would be drugs like selegiline or Parnate or Nardil or Marplan. If you do take the drug in that time interval, it could lead to the serotonin syndrome: nausea, vomiting, elevated body temperature, agitation, tremor, excessive perspiration, dilated pupils, diarrhea, and seizures. You've got to be extremely careful. In pregnancy, this isn't the drug to take. At least in animals at high dose, it leads to multi-organ malformation, lead to problems with skeletal tissue forming, lead to limb deforming, limb abnormalities. So you've got to make sure that the risk is really appropriate for the benefits that a person would get taking this particular drug. And in lactating women, some's going to be found in the breast milk, so probably best to avoid. Well, this drug is not something that should be taken within 6 weeks if you've had either a heart attack or a stroke or a history of arrhythmias or heart block or congestive heart failure, or if you have mania, or if you have severe liver disorders. Actually, you've got to be careful of taking the drug in a variety of situations. And if you withdraw from the drug, you have to do it slowly. You shouldn't do it abruptly, because you can have some transient withdrawal effects. They tend not to be too severe. You develop some nausea, headache, maybe lack of energy or restlessness, maybe some irritability or abnormal dreams and sleep-related changes. Overdose is a particular problem. Overdose with amitriptyline may be more dangerous than with most of the other antidepressants. In fact, 2 of 5 deaths from all antidepressants seem to be related to amitriptyline. The incidence has increased about 2-fold in the past 15 years. So what are the symptoms of overdose? Symptoms of overdose of the medicine: those people who take too many of the pills are going to dilate the pupils, and some become drowsy, or others become agitated. The reflexes are increased, the muscles are rigid, can develop vomiting and arrhythmias and heart failure and respiratory depression and convulsions and coma. And some people die, unfortunately. Have to be especially careful with this drug in elderly individuals. Elderly individuals, especially men, have a history of an enlarged prostate. Well, this drug can cause urinary retention and blurred vision, trouble driving a car, worsen narrow angle glaucoma, cause dry mouth, also cause cognitive impairment, confused thinking, sedation, sometimes lead to delusions or even delirium. The way the drug works is hypothesized. We think it works as an SSRI and an SNRI, works against reuptake of serotonin or norepinephrine, so there's more around that bathes the nerve terminals. Doesn't have anything to do with the dopamine receptors, but it also works in a variety of other areas within the brain. It works on the histamine receptors as an antihistaminic. It works on the muscarinic cholinergic receptors. It works on the sigma receptor. The sigma receptor is an interesting receptor. It's a non-opioid receptor, but it's implicated in pain and depression and cocaine abuse and schizophrenia and cardiovascular function. That's why we have some of the side effects. It also works on adenosine. It blocks the uptake of adenosine. That's involved in pain and cardiovascular function and inflammation. And it also interferes with the way some chemicals go from the outside of the cell to the inside of the cell. Chemicals like calcium or potassium or sodium. Well, when you take the drug, it's quite readily absorbed from the gastrointestinal system. It's altered in the body to another antidepressant, also a tricyclic antidepressant, called nortriptyline. Actually, the levels of nortriptyline and amitriptyline are about the same in an individual, circulate around the body attached to plasma proteins. 30 to 50% goes out in the urine as metabolites, and a small amount goes out in the feces. The half-life of the drug, the time it spends inside the body, it's about 25 hours, so you really only need to take the pill once a day. We can monitor the therapeutic levels. Therapeutic levels are between 75 and 175 nanograms per milliliter. But that's not really as important as knowing if the levels are too high. If they're too high, you risk arrhythmias, other kind of medical issues. Well, by monitoring the drug, by monitoring the blood to see how much of the drug is in there, we can tell if you're taking the medicine, or if you say you're taking it, well, we can find out maybe you're not absorbing it, or you're developing toxic levels. And elderly individuals who have slower gastrointestinal mobility and maybe decreased liver metabolism, well, in those people, the drug level tends to become elevated. Now, if we look at people who take the amitriptyline, they fall into 4 different categories as far as the metabolism is concerned. Some people are very poor metabolizers, others are intermediate. Some are extensive metabolizers, and others are ultra-rapid metabolizers. Now, the poor metabolizers account for about 1 in 10 individuals. They can have blood levels up to 8 times normal, so they're at greater risk of toxicity. Well, for those people, we think that this isn't really an appropriate kind of therapy. On the other hand, extensive metabolizers account for somewhere between 3/4 and 90% of the population. Those are the people for whom we have most of the information. But there are people who are ultra-rapid metabolizers. We give the drug, they don't get any effect. Give more of the drug, they don't get any effect. That's why we can monitor the blood level and find out, oh my goodness, the person really is taking the drug, but the drug isn't getting into the system. Now, even though it's only approved for its antidepressant effects, we know that it's used for a variety of other conditions. How does it work? Getting back to the antidepressant, well, it works actually as well as any other antidepressant. All of the antidepressants, doesn't make any difference what kind of advertising you hear, all of the antidepressants work about the same. None of them are curative. They can reduce the symptoms. And basically it's a trial and error approach. Here, try this drug. And we individualize it considering the individual, the other medical issues the person has, the likelihood of side effects, the cost of the drug. All of those things should be important. The tricyclics, like amitriptyline, well, they tend to be every bit as effective as the more popular drugs, the Celexa and the Paxil and the Prozac, but they have different kinds of side effects. So we look at the side effect profile. So it used to be they were the first choice. Now they've sort of fallen behind, but at least as far as the cost is concerned, very inexpensive drugs. Question is just what kind of benefit is the individual going to have? And as I said, all of the drugs seem to offer the same benefit. Now, let's turn to some of the other uses of the drugs. We have limited evidence of benefit, poor studies, small studies, questionable methods, and short follow-up. But as far as treating pain is concerned, this drug is basically at the top of the line as far as the pain people get after shingles. We call it postherpetic neuralgia, or the pain in the limbs with diabetes, the diabetic peripheral neuropathy. Works just as well as Cymbalta or Lyrica or gabapentin. There's going to be a decrease in pain. Decrease is about 25%, better than it would be if you were taking a placebo. If you can get 40 to 50% relief, consider yourself lucky, because none of our drugs are very effective for neuropathic pain. And by the way, the opioids, the oxycodone and hydrocodone, they're not first choice, second choice, or even third choice. For migraine headaches, they help to prevent the headaches. Now, most people are aware of the brand new class of drugs, the drugs that act against the calcitonin gene-related peptide. Those are drugs like Aimovig and Adjuvant and Emgality that are advertised incessantly. But do they work any better than the old-fashioned drugs, the less expensive drugs, the beta blockers like propranolol or metoprolol, or the drugs like topramate or valproate? No, they all seem to work basically about the same. And there's good evidence that amitriptyline is right there in that category. In fact, the U.S. Headache Consortium considers it a Group 1 preventive medication for those people who have at least 4 to 6 migraine headache days per month. There's very good strength of the evidence. They're a very legitimate drug. It's used as a sleeping pill. And as a sleeping pill, there's moderate quality of evidence that it improves the sleep efficiency or efficacy. It increases the total sleep time. Doesn't make you get to bed necessarily any quicker, but it seems to be helpful at a low dose for a lot of people. But remember all of the side effects I discussed. In fibromyalgia, and people who hurt all over, who have fatigue and poor sleep and memory problems and anxiety and depression, the FDA has approved Cymbalta and Lyrica and Savella. Savella is SSRI and SNRI. It's only used for fibromyalgia. But there's pretty moderate quality evidence that amitriptyline is a drug that at low dose certainly can increase the sleep and decrease the pain and fatigue. So it might be a worthwhile treatment. There's some women who develop a condition known as interstitial cystitis. And with interstitial cystitis, also called the bladder pain syndrome, it can be a chronic debilitating condition where there's pelvic pain associated with multiple urinations that occur both during the day and during the night. Not only do the urinations occur, and you have the urgency and the frequency and the nocturia, and it lasts for more than 6 weeks, and it's not due to an infection. Amitriptyline seems to be very helpful in that. And who would think amitriptyline might be good as an anti-itch medication, either taken orally or ground up as a cream? Seems to work especially well in people who have itch due to kidney failure or neurodermatitis, or what we call psychogenic itch. There's nothing wrong with the skin, they just itch. Seems to be at least moderately effective, maybe due to the antihistaminic effect. And at the 139th annual meeting of the American Neurologic Association in 2014, they presented evidence that it was better than Lyrica for people who have low back pain. Again, start at 10 milligrams, gradually increase up to about 50 milligrams. And for people with chronic cough, cough without any etiology, maybe after an upper respiratory infection, maybe it's psychogenic. But in 2/3 of the people, they seem to benefit by at least a 50% reduction in the incidence of cough. And it's persistent if they take the medicine. So amitriptyline, it's an old workhorse. It's been around for a long time. At least as an antidepressant is concerned, it's as good as any of the others. We consider the side effect profile, and that's what selects which medicine a person should take, not all this advertising. It's used for a large number of other conditions for which the evidence is either small or maybe modest. But certainly for conditions that a person has where we don't have any kind of decent therapy, for chronic pain or for migraine prevention or fibromyalgia, it may well be worth trying amitriptyline under appropriate circumstances. Well, if you want more information about some of the antidepressants and some of the other issues, especially migraine headache, we have videos on most of those topics. So stick with us. Thanks for watching. I'm Dr. Ken Landau.